You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is June 22nd, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, common immunomodulators. Our presenter is Dr. Marc Serota. He's an Allergy Immunology Fellow at Children's Mercy Hospitals and Clinics. Welcome to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri, where today is June 22nd, 2012. It's the first day of summer, so happy summer, everybody, although it's felt like summer for the last month already. It's been pretty warm out. We're going to be joined by Dr. Serota this morning. Dr. Serota is a second-year allergy fellow, but this is your last day as an allergy fellow, isn't it?
Sure.
So, congratulations for your graduation.
Thank you.
Good luck in your future plans. I'm sure you'll do very well. So, as his farewell presentation to us, Dr. Serota is going to talk with us about common immunomodulators. So, without any further delay, take it away, Dr. Serota.
Yeah, thanks, Dr. Porto. Close and pause, right? You're good.
Huh?
Put the screen back on there.
I believe so.
Yes. All right. So today I was asked to talk about the common immunomodulators. I sort of tried to pick out what was relevant to the allergist and the things that we most commonly see. So things that our patients are on, but we don't necessarily have a lot of experience with them. So the disclosures are none. I did use trade names to familiarize the learner with the products that we're discussing. Again, since the point was to familiarize ourselves with the common immunomodulators, I thought it was important to know what names they might be called, so I hope that's okay. The objectives of the talk: at the conclusion, participants should be able to describe the mechanism of action of common immunosuppressive agents, associate specific diseases with the use of a particular agent, and give a broad overview of the common side effects, warnings, and monitoring issues associated with each agent. So this is just some pre-test questions here. First one's, which of these agents is commonly used as prophylaxis for organ transplant rejection? Is it Rituximab, Mycophenolate, Infliximab, or Methotrexate? Number two, for which of these agents should hepatitis B status be established before starting treatment? Rituximab, Mycophenolate, Infliximab, or all of the above? And number three, which of the following is pregnancy category B? Infliximab, Methotrexate, Mycophenolate, or none of the above? Just as an overview, immunosuppressants are a class of drugs. They're designed to alter some function of the immune system. The function that is inhibited determines not only the clinical effects, but also the potential side effects. Just some general principles about immunosuppressive agents in general. All immunosuppressive agents carry the risk of infection and malignancy, as these are the primary functions of the immune system. Many other side effects have been reported, given that these drugs are designed to be toxic to your body in general and the immune system, basically dividing cells. So there's a wide range of side effects for each of these, but there's always a common theme of infection and malignancy. They're used primarily in the treatment of cancers, organ transplants, or autoimmune diseases. And when we get to the specific uses of each agent, I'll talk about the labeled uses, and then I'll try and give a little bit of background on some off-label uses that they're commonly used for. And basically, I just want to start by saying the talk's designed to give a broad overview. This is certainly not a comprehensive talk about all immunosuppressive agents. And we're not going to go into great detail about any one agent. It's basically designed just to give the learners some general principles and overview. So for each drug we talk about, I wanted to talk about the drug name and the trade name again, so whichever one you hear you'll be familiar with, the appearance of the drug, the mechanism of action, some labeled uses, some unlabeled uses, the dosing, some warnings and contraindications, the common adverse reactions, and what you need to be doing if these patients are on these medications in terms of monitoring them, in terms of laboratory and other things. So the first one we're talking about is mycophenolate. It's also called Cellcept. It's also called Myfortic. That's an example of what it looks like. So its mechanism of action is it exhibits a cytostatic effect on T and B lymphocytes, and it does that by inhibiting inosine monophosphate dehydrogenase, or IMPDH, which inhibits de novo guanosine nucleotide synthesis. So T and B lymphocytes are dependent on that pathway for proliferation, so if you inhibit that pathway, you inhibit their ability to proliferate. This is just basically trying to show the mechanism of action here, and it's kind of a busy slide, but basically the ultimate result is that it inhibits the T and B cell proliferation. So some uses of this drug, the most common one is prophylaxis of organ rejection, and it's used concomitantly with cyclosporin and corticosteroids in patients receiving allogeneic renal, cardiac, or hepatic transplants. But there's a lot of unlabeled uses, and this is kind of a common theme throughout. There's the labeled uses that were really well studied, but then people have extrapolated these things out to other uses as well. So it's also used in the treatment of rejection in liver transplant patients that are unable to tolerate some other immunosuppressives like tacrolimus or cyclosporin, mild rejection in heart transplant patients, treatment of moderate severe psoriasis. It's used in the treatment of proliferative lupus nephritis. It's used in the treatment of myasthenia gravis, and it's used in prevention and treatment of graft versus host disease, and probably many other off-label uses that people have used it for, but these are some of the common ones that have been used. So the dosing, this isn't related for memorization or anything, just to kind of give you a general idea. Basically, for most things, it's around 1 gram twice daily for the transplantation rejection, or sometimes a little bit more or less, and IVs is different, so you can kind of see the different dosings there. And it's a little bit lower if it's for lupus nephritis, a little bit more if you're using it for psoriasis. So the pediatric dosing is based on the body surface area. So it's somewhere between 1 gram and 2 grams, and there's a little bit of art of medicine in terms of the specific disease that you're using it for. So for monitoring for Cellcept, you want to get a complete blood count weekly for the first month, then twice monthly during the second and third month, and then monthly thereafter through the first year. You want to be checking renal and liver function, and you want to check a pregnancy test prior to initiating in females of childbearing potential. It's pregnancy category D, so that's obviously concerning. It's something you want to check for. Common adverse reactions, you can have diarrhea, leukopenia, sepsis, vomiting, opportunistic infections, all the common things you would think about. There's some warnings you need to consider. Sorry that the lettering's a little smaller. Patients receiving immunosuppressive regimens, increased risk of developing lymphomas, other malignancies, particularly of the skin. So again, the malignancy issue comes up. Susceptibility to infection, of course. There's risk of opportunistic infections, and there's a risk of reactivating latent viral infections. And there have been reports of fatal cases of progressive multifocal leukoencephalopathy and BK virus-associated nephropathy. So those are things to be monitoring for. With the progressive multifocal leukoencephalopathy, there have been reported cases. You get hemiparesis, apathy, confusion, cognitive deficiencies, ataxia. Those are the most frequent clinically observed features. There are teratogenic effects, as we discussed, so that's why it's pregnancy category D. And you want to monitor patients for neutropenia. If the ANC drops, then dosing should be interrupted or the dose reduced, so you're going to be monitoring for that. And sometimes that can even be prohibited of using the drug at all. There's also been cases of pure red cell aplasia. So that's something else to be observing for with your CBCs. So contraindications, some of these are pretty self-explanatory, but hypersensitivity to the drug or any of the components of the drug. Intravenous formulation is contraindicated in patients who are allergic to polysorbate 80, which is used as an emulsifier in foods and as an aqueous stabilizer in drugs. So if you have an allergy to that, that's used as a stabilizer in the IV form. So that's it for that one. The next drug we're going to talk about is Infliximab, which is also called Remicade. So its mechanism of action is it's a chimeric monoclonal antibody that binds to human tumor necrosis factor alpha, TNF-alpha, and it interferes with endogenous TNF-alpha activity. So elevated TNF-alpha levels have been found in tissues of patients with basically various inflammatory processes, rheumatoid arthritis, ankylosing spondylitis, psoriasis, Crohn's, ulcerative colitis. So if you're blocking that, then you're reducing the inflammation in those conditions. The biological activities of TNF-alpha is the induction of pro-inflammatory cytokines, enhancement of leukocyte migration, activation of neutrophils and eosinophils, and the induction of acute phase reactants and tissue-degrading enzymes. So again, if you're blocking that substance, then you're potentially reducing all of those things, which is important in the diseases that we're going to talk about. So again, it's a chimeric monoclonal antibody, so it's basically blocking TNF-alpha here, just showing that in picture form. So the uses for Infliximab, again, we're going to do labeled and unlabeled. So the labeled is treatment of moderately to severely active rheumatoid arthritis, and that's in combination with Methotrexate. Treatment of moderately to severe activated Crohn's with inadequate response to conventional therapy. Treatment of psoriatic arthritis. Treatment of chronic severe plaque psoriasis. Treatment of active ankylosing spondylitis. And treatment of moderately to severely active ulcerative colitis. So basically it's a lot of autoimmune diseases and things that we commonly see people have, in our clinics, some of these autoimmune problems. So the dosing, in general, it's basically 5 mg per kg IV at 0, 2, and 6 weeks, and then 5 mg per kg every 8 weeks thereafter. So you start with kind of a build-up, and then once you reach a steady state, then it's basically 5 mg per kg every 8 weeks. You may increase it up to 10 mg per kg for poor responders. From what I was reading, most people respond with a 5 mg per kg, but sometimes you might have someone who's not responding well, and you can go up to 10. So there's some warnings associated with this, of course, as well. There's autoimmune disorder where positive anti-nuclear antibodies have been detected in patients with negative baselines. So we're not talking about people who already had autoimmune problems or people who are negative to start with. And these can be things like lupus-like syndromes, and basically you need to monitor them for that. And if this turns positive and they start having these symptoms, you should discontinue. There's hematologic disorders, leukopenia, neutropenia, thrombocytopenia, pancytopenia have been reported. It's pretty much common for most of the drugs. Again, liver reactions, most of the medications we're talking about have some liver effects because they're cleared by the liver. Severe hepatic reactions, hepatitis, jaundice, acute liver failure have been reported during treatment, and you want to discontinue the medication with jaundice or marked increase in liver enzymes greater than 5 times the upper limit of normal.
It's strange that it can cause autoimmune disorders since it's used to treat them. You'd think that the treatment with it would actually prevent that from happening. Any idea why that, or what the mechanism is?
I tried to look into that a little bit because I found that kind of unusual too. The best answer I could find was that it kind of was more of a balance issue with the different cytokines as opposed to like, one hit of the immune system where all it's doing is anti-inflammatory. You're kind of throwing things out of balance, and anytime you do that, you can have other parts of the immune system that become overactive.
So maybe if you knock interferon alpha or TNF-alpha down, then something else comes up in response, and that thing that comes up does more harm than knocking down the TNF-alpha. Could it also, are there antibodies that are formed too? You said it was chimeric, so it's not fully humanized. And could those form immune complexes that might lead to the development of autoimmune?
Yeah, it's possible. I didn't read anything specifically about that, but that sounds like a good thought.
You didn't mention it here, but you see a lot of these things advertised on television for different diseases, and they always talk about screening for TB and everything.
Yeah, that's pretty much common throughout. I think I talked about that with a different drug, but some things you do basically uniformly when you're starting from immunosuppression. So you check them for latent TB, you check them for hepatitis B. There's a few different things that you want to know about latency of before you start them on immunosuppressives. And that's, TB would be one, hepatitis B is the other major one.
Yeah, it is strange. These are advertised on TV. You watch the news in the evening, and they're telling you to ask your doctor about using this drug for.
Has something to do with money.
These are pretty heavy guns for TV marketing.
Sounds like these drugs are pretty lucrative. And when I was working in a rheumatology clinic at Truman, there was patients that came over all the time that would ask for a specific immunosuppressive drug they'd seen on TV for their rheumatoid arthritis.
Really?
Like that, so.
Did the doctors give it to them?
No, I mean they just discussed the various options, but I don't know. I wouldn't be going to my doctor asking for an immunosuppressive,
The negative awesome on television, they spend 10 seconds talking about the drug, 20 seconds talking about the negative side effects.
But they're usually listed in a very quiet monotone under the while the patient's walking around smiling and being happy.
By somebody who can speak really fast.
So it sort of sends mixed messages, but go ahead.
And then the last warning there is hepatitis B, which we were just talking about. So you can get reactivation of your hepatitis B. So you want to check their status beforehand, and then monitor their LFTs during treatment. And if they're having a problem, then it may require antiviral therapy and discontinuation of the immunosuppressive while you treat them, because you don't want to give them liver failure while you're trying to treat their rheumatoid arthritis.
And then you can use it to treat their liver transplants.
Exactly. So there's some more warnings about these drugs, and they have a lot of them, by the way. I just tried to pick out the highlights. Hypersensitivity or infusion reactions. So these may occur within 2 hours of infusion. The medication and equipment for management of hypersensitivity reactions should be available. So it's not something you want to be doing in an inappropriate setting. And you can basically interrupt or start a slower rate after that happens. You can pre-treat if they're having these issues, especially if they've had prior infusion reactions. And serum sickness-like reactions have occurred, and that may be associated with a decreased response to treatment. So again, we were talking about the immune complex issue. They have reported some serum sickness-like reactions, so there's a possibility. So of course, infection, malignancy, we always talk about. A lot of these things have black box warnings, so Remicade is one that does. Lymphoma and other malignancies have been reported in children and adolescents receiving TNF blocking agents. Most of them, about half, are lymphomas, Hodgkin's and non-Hodgkin's. And then there's also a black box warning about hepatosplenic T-cell lymphoma, which has been reported in patients with Crohn's disease or ulcerative colitis treated with Infliximab, and concurrent or prior azathioprine and mercaptopurine. So there's always black box warnings for these medicines. But the interesting thing is just pregnancy category B. So if you have a pregnant woman who has rheumatoid arthritis, one of these other autoimmune diseases, Infliximab would be a good option. So adverse reactions here, sorry for the small slide. Tried to list everything on one so you kind of get an overall picture. Basically, I just broke it down to greater than 10%, 5 to 10%, less than 5%. Like Dr. Barnes was saying, they list these side effects on the commercial. It just makes your head spin. But I thought the ones that greater than 10%, I bolded those because those were the ones that were most common. So you can get headache, nausea, diarrhea, abdominal pain, some hepatic issues like we talked about, some respiratory tract infections, sinusitis, and then some miscellaneous things like we talked about the development of the nuclear antibodies, all those other kind of infection, infusion reactions we talked about. So those are the common ones, and then as you go down the list, it's less likely. Once you get down to less than 5%, I mean, these things are designed to be somewhat toxic to your body, so it's like less than 5% sounds like it could almost be just about anything. So for monitoring for Infliximab, what you want to do is monitor for improvement of symptoms and physical function assessments for something like rheumatoid arthritis. During the infusion, if a reaction is noted, you monitor vital signs, and depending on the reaction severity, you may want to discontinue. Like we talked about, latent TB screening prior to initiating therapy. And then you want to check CBC with DIF. Signs and symptoms of worsening heart failure, because that can be associated. HBV screening, like we talked about, so hepatitis B carriers, you want to monitor them for several months following therapy, and of course during therapy. Monitor for signs and symptoms of a hypersensitivity reaction, symptoms of those developing the anti-nuclear antibodies or lupus-like syndromes, and signs or symptoms of malignancy, particularly lymphomas alone. So contraindications, again, hypersensitivity to the drug or any component of the formulation, of course, or doses greater than 5 mg per kg in patients with moderate or severe heart failure. So heart failure is an issue with this drug. So we talked about you could go up to 10 mg per kg, but if they have heart failure, you don't want to go above 5. So the next one we wanted to talk about was Rituximab, which is also called Rituxan. That's what it looks like. So this mechanism of action is another monoclonal antibody. This one's directed against the CD20 antigen. So we talked about TNF-alpha, and now we're talking about an antibody against CD20, which is, of course, the antigen on B lymphocytes. So CD20, as we know, regulates cell cycle initiation and also possibly functions as a calcium channel. Rituximab binds to the antigen on the cell surface, activates complement-dependent B-cell cytotoxicity, and mediates cell killing through an antibody-dependent cellular toxicity. So basically, it's an anti-B cell. B cells are believed to play a role in the development and progression of rheumatoid arthritis. Signs and symptoms are reduced by targeting B cells, and the progression of structural damage is delayed. So since B cells are believed to be part of the mechanism of rheumatoid arthritis, this is used. And it's also used for other things, as we know. So again, just kind of in picture form here, you have a monoclonal antibody binding to the CD20, and then that induces complement activation and ultimately cell death and apoptosis. So some uses of the anti-CD20. Treatment of CD20 positive non-Hodgkin's lymphoma, of course. So if you have a lymphoma with CD20, naturally you want to use something that's anti-CD20. Relapsed or refractory low-grade or follicular B-cell non-Hodgkin's lymphoma. So basically any of the B-cell lymphomas there on the list are all labeled uses of the drug. So I put those in one category. And then it's also used for treatment of moderately to severely active rheumatoid arthritis, usually in combination with methotrexate, in adult patients with inadequate responses to one or more of the TNF antagonists. So if you're using one of the TNF antagonists, we discussed one, then you can use this as an add-on or alternative. It's also used for treatment of Wegener's in combination with glucocorticoids, and it's used for treatment of microscopic polyangiitis in combination with glucocorticoids. So basically you have the B-cell tumors and then some other miscellaneous uses, and the rheumatoid arthritis, as we talked about. B-cells play a role in that, so it's been shown to be effective. And then we have some unlabeled uses. Again, this list I'm sure is not complete, but this is the common unlabeled uses. So it's been used in the treatment of other types of cancers other than just the B-cell lymphomas. Burkitt's comes to mind. Some of the other Hodgkin's is lymphocyte predominant, not necessarily B-cell. Some of the other lymphomas you can see there. It's also used for Waldenstrom's macroglobulinemia, post-transplant lymphoproliferative disorder, autoimmune hemolytic anemia in children, ITP, refractory pemphigus, and treatment of steroid refractory GVHD. So probably the bottom ones here are the ones where we might come into play for things like lymphoproliferative disorders and things like that. Potentially you could use Rituximab. So the dosing, so in general it's 375 milligram per meter squared, usually for 4 doses. I'm just putting that in as a generalization because for each of those conditions we just discussed, literally there's a slightly different dosing for all of them. So rather than bore you with that, I just gave you the generalization. And the time course and repeat dosing based on specific disease protocol. So if you're treating one of those specific diseases, you basically look it up, but just giving you the overview here. So again, the warnings, similar stuff, of course, infections, bowel obstruction or perforation, abdominal pain. These have been reported and rarely fatal, with an average onset of symptoms of around 6 days. Complaints of abdominal pain should be evaluated, especially if early in the treatment course. So that's something that's kind of unique that you want to look out for. Mucocutaneous reactions. This is another box warning. Severe and sometimes fatal mucocutaneous reactions like lichenoid dermatitis, paraneoplastic pemphigus, Stevens-Johnson, TEN. Some pretty severe stuff have been reported. And it occurs anywhere from 1 to 13 weeks following exposure. So you should discontinue this in patients experiencing those, and they should never receive the drug again. So it's, again, all these drugs are like not taken lightly. They all have a lot of issues. Similar to some of the other drugs we've talked about, can also cause PML, and that's also another black box warning. It's due to JC virus, and this has been reported with Rituximab, and also may be fatal. So you should, of course, discontinue the drug if that occurs, and consider reduction, discontinuation of other concurrent chemotherapy or immunosuppressants in such a situation. These are rare reported things, but they were reported with the drug, so they are in the black box warnings, so I included them. You can have renal toxicity, which can be fatal in patients with hematologic malignancies. Patients who received combination therapy with cisplatin and rituximab for non-Hodgkin's lymphoma experienced renal toxicity during the clinical trials. So that was a situation where it's usually reported. So there may have been some additive effect with the cisplatin and the rituximab or something. And it's not always clear, you know, a lot of these patients have been on multiple immunosuppressive agents and other comorbidities, but they do report this as part of the medication, so I'm telling you about it. You can have tumor lysis syndrome, of course. That would be in the setting of someone who has a tumor, which can lead to acute renal failure and dialysis. That's basically the result of breaking down the tumor and having its products released quickly in large doses into the body. You can have infusion reactions also with this one. They can be severe, occasionally fatal infusion reactions, which have been reported. They're usually with the first infusion, so it's not necessarily something you think of where they need to be sensitized first. It can be with the first infusion. And they've been reported within 24 hours of infusion, so you want to monitor them closely during the infusion and discontinue with grades 3 or 4 reactions. They usually occur within the first 30 to 120 minutes and typical allergic type symptoms. In more severe cases, they talk about pulmonary infiltrates and acute respiratory distress syndrome. Some pretty severe symptoms there, as you can see. So you want to monitor them during the infusion. This is pregnancy category C. Again, adverse reactions. Again, sorry for the small I just want to kind of give you the big picture, so put it all on one page. And again, the greater than 10% ones are the ones I was looking at the most. Where you can have peripheral edema, cardiovascular type symptoms. You can also have some CNS symptoms. Those are kind of common constitutional type things that you can have. You can have dermatologic symptoms like rash or angioedema. Of course, GI symptoms. Hematologic, again, similar to all the other ones, that can drop your counts. Hepatic, of course, can always be an issue. You can have neuromuscular and skeletal issues, respiratory, and then all those miscellaneous things down there. So, I think I highlighted the more unusual points about the medicine, and then all these other things are reported in various percentages that can be associated with the medicine. So essentially, if someone's on immunosuppressive and they have a symptom, it's probably listed somewhere in the immunosuppressive's adverse reaction. And these are some of the less common ones. Again, nothing that you would be too surprised about, I don't think. Okay, so monitoring for rituximab, you want to do CBC with differential, and basically you obtain at weekly to monthly intervals and more frequently in patients with cytopenias, or 2 to 4 month intervals in rheumatoid arthritis patients or some of the other non-malignancy disorders. You want to check peripheral CD20s so you know what your counts are before you're starting. You want renal function and fluid balance. And then, of course, during the infusion, you want to be monitoring them. Again, you screen for hepatitis in high-risk patients prior to initiation. And the NHL guidelines recommend screening all non-Hodgkin's lymphoma patients prior to therapy. And remember the abdominal issue, so complaints of abdominal pain, especially early in the course of treatment, should prompt a thorough evaluation and appropriate treatment. And again, also remember the PML issue. So if you're developing that, or of course the other serious thing would be those severe dermatologic TEN type things. So those are the big things you're monitoring for. Okay, and then also wanted to mention methotrexate. So its mechanism of action is it's a folate anti-metabolite. It inhibits DNA synthesis, and it irreversibly binds dihydrofolate reductase, which basically inhibits the formation of reduced folates and results in inhibition of purine and dimethylic acid synthesis. So essentially you're blocking DNA synthesis. So if cells can't make DNA in the S phase of replication, then they can't reproduce themselves, and you get immunosuppression. So methotrexate's uses, again, labeled. So there's many oncology-related uses. You can see some of them I've listed there. And then non-oncology uses, again, a lot of the autoimmune type diseases, treatment of psoriasis, severe rheumatoid arthritis, JIA, things like that. And again, I'm sure there's other uses that people are using this for. Here's some other ones. Treatment and maintenance of remission of Crohn's, ectopic pregnancy. So this is pregnancy category X. So there's not too many drugs we use in our specialty that are pregnancy category X. So this is severely contraindicated in pregnancy. You can use dermatomyositis, polymyositis, bladder cancer, CNS tumors, some other types of tumors, acute graft versus host disease prophylaxis, medical management of abortions. Methotrexate in early pregnancies is used as medical management for abortions. Systemic, so SLE, lupus, Takayasu arteritis. There's a lot of, because it has such a broad mechanism of action of preventing DNA synthesis, it also has broad uses. So monitoring, it really differs based on the disease you're treating, so I just tried to give some general guidelines. So lab tests performed on day 5 or 6 of the weekly methotrexate cycle to detect leukopenia and avoid elevated LFTs. CBC with diff and platelets baseline before you start, and then 7 to 14 days after initiating therapy or dose increase, and then every 2 to 4 weeks for the first month, and it kind of goes up after that. You want to get BUN, creatinine, LFTs. Of course, we talked about many times now the PPD for latent TB, chest X-ray if there's underlying lung disease, LFTs. Sometimes a liver biopsy is required if you have patients on methotrexate who have persistent abnormal LFTs or a history of liver disease, because you can have reactivation of hepatitis. So if they're on methotrexate and they're having liver issues, there are certain criteria for doing liver biopsies. And again, ectopic pregnancy is unlabeled use, but prior to therapy, you want to measure the serum HCG, CBC with diff, all the things, liver function, serum creatinine. And basically you do that because you want to look at the HCG level and see if it decreases between the treatment days. If it decreases by greater than 15%, then you don't need an additional course. If you continue to measure HCG weekly until it's no longer detectable, if it's less than 15%, then you repeat the dose. So that's why you monitor the HCG level so you can see if they need more doses or not for ectopic pregnancy. Again, multiple boxed warnings, of course. Acute renal failure, you can have bone marrow suppression, you can have dermatologic toxicities similar to the last drug we talked about, Stevens-Johnson. You can have TEN, erythema multiforme. You can also have diarrhea and stomatitis, and again, may require interruption of therapy. So it's a wide mechanism of action. So it has wide uses, but also basically can affect any system of the body pretty much. Of course, it can affect fertility because of the issues with the DNA synthesis that it's blocking, hepatotoxicity, which we talked about. Again, it can cause lymphomas. Pretty much all the drugs we're talking about can cause that. And use of even low-dose methotrexate has been associated with the development of malignant lymphomas. So even if you're using relatively low dose and some of the other systemic side effects aren't happening, you can still get lymphomas with these. You can have neurotoxicity, you can have opportunistic infections, of course, pneumonitis, and again, tumor lysis syndrome. So that's it. I tried to stick to the common ones. Some of the medicines we use in the allergy world, like Rituximab, methotrexate, you can use for difficult to treat immune system problems like arthritis or really severe chronic urticaria and things like that. So I tried to give a general overview, and this definitely isn't a complete list, and I'm sure there's other uses and things that I didn't go over, but I just tried to give a broad overview of the common ones.
think I might want to stick with my chronic urticaria.
Yeah, Rituximab is probably a little. It's kind of a scary thing, honestly. I looked into these drugs in pretty good detail, and the more you read about them, the more you realize they're really poisons that were developed to, treat cancers and autoimmune problems and stuff. But they have so many side effects too that.
Did you read any
really
about desensitization protocols for any of these?
I didn't look into that specifically. I know the monoclonal antibodies and some of the other ones, they basically just said to reduce the rate of the infusions, and then you can pre-treat with antihistamines and steroids, but I didn't look at specifically like dosing protocols for desensitization.
Mariana Costello in Boston has done a lot of desensitization protocols for especially adult women who have had malignancies and been on a whole variety of chemotherapeutic agents. And so she's done it for more than just, IgE mechanism sort of thing, and has had pretty good success with going through some of those. I know she's done through a lot of these drugs used in chemotherapy. That's why I was curious if you came across. I don't know specifically if she's done any of these. But
the one I've done in my fellowship recently was the anti-thymocyte globulin, which I think she wrote that paper, I'm pretty sure. And so we did that for a child who had like hypotension and what looked like an allergic reaction to that. So and basically the gist of the protocol is that you start out really dilute, like 1 to 10 million dilution, and then you go up from there. So you basically just go really slowly with really dilute, and then go up. And he tolerated that fine, and he stayed on it for a week or 10 days, and he didn't have any problems. So. And the other thing with the monoclonal antibodies and anti-thymocyte globulin was each batch is a little bit different in terms of its antigens. So just because you have a reaction to one batch, who knows if that antigen's in subsequent batches or not. So a little bit is playing the odds and being safe.
Chitran actually found Dr. Costello's review article on the desensitization protocol and her experience with these chemotherapeutics. I'll send it out to everybody.
Actually, sure. And Rodney, I think I had Rodney give a talk, I guess Tom O'Foley gave a talk where he went through all her protocols on cola.
We had contacted her for the Sunday on the phone.
Yeah, we called her and talked to her about it.
She was very helpful.
All right, so just quickly go over the post-test here. If there are any other questions. So which of these agents is commonly used as prophylaxis for organ transplant? So that's Mycophenolate or Celcept. Talked about that. For which of these agents should hepatitis B status be established before starting treatment? Again, we talked about that. That's all the above. So for all these medicines, you have to do certain pre-treatment things, like checking Hep B status, getting baseline labs, checking a TB test. And which of the following is pregnancy category B? So remember that was Infliximab, and remember Methotrexate is category X.
Never heard of it.
If I saw this question and hadn't done this lecture, I probably would have thought it was none of the above.
It means it's definitely bad.
So it's actually used to abort pregnancy, like an ectopic and other things. Don't want to use that. Yeah, so you can remember the X and methotrexate.
All right. Any other comments from the group or thoughts?
Well, did you talk about tacrolimus?
No, I didn't go over tacrolimus.
Because there's this one interesting phenomenon for allergists, the tacrolimus that I've seen that, and it's being reported. Tacrolimus patients who get it for graft rejection problems can develop IgE-mediated food allergy. So it's very interesting. So I have about 5 patients that I'm following with Dr. Daniel, who does the liver transplant. It's very interesting. A child had no problem with eating egg or whatever the food was before. And after the tacrolimus introduced, the child developed an allergy. And I did challenges and everything. And then when I was in NIH for a food allergy review, I found that one center had applied for a grant to study that very thing. So clearly, reported on in one center. The only interesting addendum I have is one patient who was on tacrolimus was weaned off it because the child developed side effects and was switched to sirolimus, which is another product. And the food allergen levels started dropping after that. I don't know. The theory is that it's some T cell mediated T lymphocyte or
Some
eat
kind of
or whatever.
regulatory defect.
Yeah.
Is there anything, is there any specific foods, or is it anything?
No, I don't think there's any specific foods. You might want, my patients have had different foods, so you can look into it more, but that's a very interesting topic to explore, but it's really interesting because it's got to do with a transplant, so if you can't make it a transplant, introduce them to deal with the drug and change your immunomodulation.
Well, food for thought and something to chew on.
Thank you, Mark.
Any other thoughts, comments? Thank you, Dr. Serota, and good luck in your next endeavors. And we'll stop there. This is Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City. We'll see you on Monday. Bye-bye. Have a great weekend, everybody.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.